Principal Chief James Floyd here in your office. Want to thank you for the time first off for this interview and give you some questions out there. Hopefully you've had a chance to study up, but I got a lot of things we want to cover here though. We'll start off with the maturity date for the Eufaula Okemah loan. What is that date?
The date of the maturity of the Eufaula loan is 4 years after the loan is initiated. And so it is a balloon payment. So I'm not sure the exact date it was completed, but 4 years from that we have the payments due.
Okay. What's the plan for when the payment comes due in full?
Well, the plan is we pay it at that time. We generate the revenue from the healthcare system. We're working on that right now, and we've increased collections. There was a reserve fund previously that's been depleted, but what we will do is the revenue that would have gone to the reserve fund will go to the loan payments to remove that debt, because the reserve fund should have paid the debt in the beginning.
To your knowledge, is the architecture fees for Okemah and Eufaula, are they within the loan or are they in addition?
They are included in the loan.
Okay. The term for the $65 million bailout loan, what's that?
Term in regards to the date. It is a revolving loan.
Right.
So there is no end date.
And does it contain a waiver of sovereign immunity?
We don't give up any sovereign immunity.
Okay.
So there would be nothing in there that would waive sovereign immunity for our tribe.
We've saw where the council is taken, even in comments from them, published quotes, taking responsibility for maybe passing things when we were working through a deficit. How does the council know if funds are available in fund accounts before they approve legislation that's sent over from the principal chief's office?
We provide information to them upon any request. So information of the financial nature is communicated almost on a daily basis to the council. Either they request it or we send it over because we want them to be informed. So we're sending over quite a bit of information so that they can have it and make the appropriate decision. So, this is kind of a two-way communication that we're having to make sure that they have the information they need.
As it is now, what's your grasp of the health board at MCN? I mean, its structure and everything, and what you'd like to see it eventually be.
Well, I know very little of the health board. Having walked in about a little over 90 days ago,
Sure.
I know that there is a health board. I think it's more of an internal management board. My plan, if I had a magic wand and could change it, I would reduce the number because I think there's about 14.
Right.
And that way, I think we could have decisions made a little more efficiently. The second thing is just the health department itself. We're having a closer relationship with them, with the executive branch, and that will even be integrated to be more closely associated with us in the future.
For clarification on the 2016 budget, was it submitted in fall 2015 or were there changes made when you came on?
I think the original bill was submitted in the fall, late summer or fall of 2015. And yes, after I came in, there was some modification of the budget and then it was passed in January.
The purpose of the Nursing Home Administration and Long-Term Care Department?
I believe those two parts, the administration and long-term care, is part of the rehabilitation center that the tribe operates, the formerly George Nye Center. So those are two components of that facility.
And you know when that was added in?
I don't know when that was added in. I imagine it's probably shortly after we took ownership of that facility.
In a couple of the budgets, there's a salary line item for an attorney, and it's since been removed in favor of a liaison. Can you talk about that?
Well, I think they're two separate things. I'm not aware, I don't have much knowledge, I'll put it that way, of the attorney. It was removed because we want to make sure that the National Council is involved with us with an attorney. And it's something that we don't have at the present time. So it allows us to work with the National Council to engage attorneys as needed. And so in lieu of previously just having an attorney on salary, which to serve, either the executive branch or the National Council, we're probably on the executive side going to more project-based needs. So if we need one, we'll use one. If we don't, we won't be paying for one. And the second part again was the you had the attorney, and your second part of your question.
The liaison.
Oh, the liaison.
If needed.
The liaison is a position whose description we're still working on at the present time. It's intended to be someone who collaborates with citizens outside the nation and helps resolve those issues. And so when we get that in place, we'll evaluate it. It'll be reported in quarterly reports to our citizens of what types of issues that we have, how it's being dealt with, and then may even indicate from which state, because it's actually international, because we have citizens that live outside the country. So we'll be dealing with issues that citizens have that we can take care of.
We're looking through the budget and things like that, found a sub-budget for Seminole Nation Health Board. Can you explain that purpose there?
I'm not entirely aware that there's a budget, but I know that it's probably for travel between here and there.
Okay.
It may not even be used because we do have GSA vehicles. I don't see that anyone would be spending the night over there. I know that the Wewoka Health Center has a board. We have membership on that board, and I believe that's what it's intended.
You come in and make a few moves just for things that make more sense, and I think that's where we are with this next question. WIC, elderly nutrition, moved from health to community and human services. Is that the reason why?
Yes, it is. We're trying to put similar programs together so we can collaborate and be more efficient in how we address issues and how we make decisions. So yes, we are moving some programs that are similar together so they can work together.
It looks like in the things that we've covered and the materials that we've gathered and the quotes that we've got, a lot of, I don't want to say blame, but a lot of people have pointed to the Cerner software being sort of a stick in the road. If it was a problem, why do you think the contract was renewed?
I'm not sure why the contract was renewed. I think that was before I came on board. Cerner is the inpatient electronic medical record that's used for the Okmulgee Hospital, the Okemah Hospital, and I think the Rehabilitation Center. We do have a claim against Cerner, and that's about the extent that I'm aware of it. If we were to dissolve the relationship with Cerner, we'd be going to another electronic record system, and presently we're looking at several.
In your previous stead as the VA director in Muskogee, did you have any experience with Cerner before, and did it cause you problems before?
I've had experience with Cerner in setting on a private hospital board in another state. Fairly large system. They use Cerner. This has been about 10 years ago, and they used it for about 3 years and then moved on to another system. I'm not sure the decision process for the tribe and how we arrived at Cerner.
Yeah. Estimated completion date of the Okemah Hospital project?
December 2016.
So we're right on schedule with that?
Yes, sir.
All right, great. The groundbreaking ceremony held last May for the Eufauna Clinic. Construction hasn't started as of yet. Any reasons that you could share with us about that?
I'm not sure about the groundbreaking, why it was done then. I can tell you where we are right now. We've had meetings with the Indian Health Service and our health department last week, and we have another scheduled for a couple weeks. There's 2 portions that we're working on that need to occur for the construction to start. One is the requirements, and that's what we discussed the last time we met with the Indian Health Services, basically the layout and making sure it fits the space that's been approved. So, for instance, the dental program needs a certain amount of square footage. That will determine the staff. Same with behavioral health, square footage and number of staff. So once we have that requirements package, then that gives the Indian Health Service the information they need to determine the staff they will fund for the clinic. It'll also fulfill the second part that they need, and that's the square footage of the entire facility and the layout. And so there's two parts to it. I think we're very close to getting that completed.
Wonderful. Do you have an estimation of the number of patients we're seeing in our facilities right now?
Somewhat.
Yeah.
We are getting more information. The information that we're looking at right now is the visits to each facility and the admissions to each hospital. We will go beyond that, and then we will begin to publish that information in the quarterly reports.
Since the health deficit has become public, have there been any changes in the health system? And talk about those.
Well,
Position.
my discussions with the health department has been we focus on basically three things. One is improve the quality of the health care and efficiency. So that's one part of it. The second part of it is to make sure that we record our workload properly and gather information about insurance and other things that we may need to properly document the visit and for the billing. And the third is just revenue generation. And it's a normal part of the healthcare system, and it's the business of a healthcare system. But primarily, it's to improve the quality of care to our citizens.
We've had some discrepancies in the information that we've gathered on the original debt assumed by the acquisition of OMH, Okmulgee Memorial Hospital. Some say $4 million, $5 million. Do you know what an actual close number is there? Is it
I think it's more like $4 million. I'd refer you to the 2014 comprehensive audit, where there is a narrative about the acquisition of the Okmulgee Hospital, and it does go into some numbers there.
The purchase price of George Nye and the debt assumed from OMH, are those paid off right now currently?
I think I was told that both have been.
Right.
So I don't think that any of that debt that we would have accumulated or any transactional costs are in the $65 million. I believe those things have been retired, and basically the deficit is the operational deficit.
Because overtime and compensatory pay and things like that were such a big part of this in our coverage, where and how is the overtime and the shift differential calculated in the budget?
It would be in, excuse me, there should be within each department kind of a subset of overtime. And so it's distributed because it's a normal part of operating the hospital. There will be some overtime. I believe, and I know that in the past it's been an excessive amount. Since I've come into office and talked to the health department, we've established a set amount per department for each month that they have to live within.
What was the estimated worth of OMH and George Nye when they were purchased? Do you remember that?
No, I don't.
Okay.
Because with George Nye, it was donated to us, and so we had to estimate the value of it. And I think the same thing with Okmulgee Memorial. There was a little bit more detail of Okmulgee Memorial because you weren't just getting the building, there were many other parts of the system. So I can't say for sure, but I think that's included also in the 2014 comprehensive budget.
Do you have an idea of how many employees were transferred from OMH and George Nye and what the cost of that transfer was?
No, I don't. I don't know the exact number.
Okay. On the 2014 budget, there's a line item on the salary pages called Extra PP. Do you know what that is?
Do you know which department it would have been in?
I don't have that on my notes. We saw that in there, and it was Extra PP. Didn't really know. So
yeah, that I don't know. Okay. The abbreviation isn't familiar to me.
What's the typical funds made in the healthcare business, and what's typical for Muskogee Creek Nation?
In terms of
just funds brought in from
Well,
care and-
for the Muskogee Creek Nation,
Mm-hmm.
the funds primarily come from the Indian Health Service.
Okay.
So you have Indian Health Service funds, you have generated revenue. Generated revenue contains many portions. There's self-pay, there's third-party payments of associated types, insurance, Medicare, Medicaid, and I think that's primarily it. But those are the components that finance the system.
New equipment approved by the council, such as the MRI, bringing in revenue or in there?
You know, I'm not real sure,
Okay.
but tribal funds have played a part of the healthcare system in contract care or purchase or referred and purchase care, and equipment. So, you know, those have been done by special appropriations by the National Council.
We've had a few citizens bring things to our attention about billing with the OMH. Basically, what it is they're getting a bill sent to their home, and this is a bill, you know, and it's also overdue or something like that. But there's a number also listed on it if you are a Creek citizen to call. Basically, it's a number to call and prove your tribal citizenship, so the bill is waived. But these citizens are proving their tribal citizenship at entry to the hospital. So what are the protections there? I mean, what if they just overlook the number? I mean, is there protections there to where our tribal citizens that bill is not to be, you know, put forth in such a way it's supposed to be waived with tribal citizenship? Are there any protections if they just, you know, sometimes it's easy to overlook a number and it's kind of fine print, so in what we saw.
Well, in general, in the healthcare industry and insurance, if you go seek care, you're going to get a statement that says explanation of benefits.
Right.
And it could be one of those, what they call an EOB form. But, you know, haven't got into that detail in the healthcare system, so I really can't fully answer your question. It could be, though, that it's an explanation of benefits. If there's a number in there to call, I suggest that the citizen call that number, because that's a protection. We don't want them charged. If we have the funds to pay for it and it's our program, they shouldn't be charged.
As an administrator, do you see that as sort of a something that may need to be fixed if they're taking tribal citizenship on entry and then maybe like putting it sort of in this kind of fine print where
Right. So you're asking a question about some processes that we're working on presently.
Right, okay.
So we're working on the processes, so if you were to come into a facility and the first person that you see should be gathering that information, just as you had indicated. In that process, all the way to billing, we're making sure that we're being efficient. If it's inefficient to be doing something, we're going to be eliminating it. So if it's an idle piece of paper that has no meaning, then there's no reason that we should be sending it out. And so you're right. If we have that up front, the processes should be working efficiently, so they shouldn't be receiving information that's meaningless.
Are citizens not able to use facilities such as MCN Health Center without health insurance?
We do see people without health insurance.
Right, and that will continue, or
As a hospital,
how does that work?
you know, if we see a patient and they don't have insurance, then we make arrangements. Either they're going to be billed personally. I mean, we're talking about non-citizens here.
Yes.
So if they're non-citizen, they'll be billed because there is a cost of care, or it's written off if they have no source of money. And we do write off some charges, but not much.
Well, we thank you so much for your time today, sir.
Thank you.
And sitting in the hot seat here, a lot of questions, a lot of things, and duly noted, a lot of these things are really not in your control to be able to be answered at this time, so we appreciate you answering to the best of your ability.
Well, thanks.
Appreciate it.
You know, the health department is big,
Right.
and there's a lot to that. Presently, we are recruiting for an outside administrator to come in. So once the outside administrator comes in and that company takes a look at our healthcare system, I think a lot of the questions that you have asked will be answered, and there will be more changes, but it will be to become stable and efficient and productive. And so the situation that we're in right now won't be repeated in the future.
Thank you, sir.
Okay, thank you, Jason.